Hello everyone. Today we'll discuss about neutrophilic disorders. So, starting off with the introduction of these neutrophils, these are the essential part of innate immunity. Okay. So, these are the essential part of our innate immunity, and these are the initial response to the recent infection. So, these comes as an initial response to any recent infections. So, talking about its morphology, these are polymorphonuclear in nature. Why it is called as polymorphonuclear? Because they have a multilobulated nucleus. So, these are polymorphonuclear. Next, these have derived its name because they stain in a neutral pink color in hematoxylin and eosin stain. In hematoxylin and eosin stain, they have a neutral pink in color. So, they have got the name as neutrophils. So, this is a short introduction about the neutrophils. Next, we'll go into its disorders. We classify these disorders into three types. 1. There's a defect or a disorders in their count. Second, disorders in the neutrophilic function. Third, when there is a defect in the neutrophil degranulation, it is third. Okay, so these are the three types of disorders. First, starting off with its count. So we have discussed in our earlier video, that is in febrile neutropenia. What is neutropenia? What is absolute neutrophilic count? So when there is an absolute reduction in the number of circulating neutrophils, then you call this as neutropenia. That is, when the absolute neutrophil count is less than 1.5 into 10 to the power of 9 per liter, then you call it as neutropenia. What are the causes of neutropenia? Next, we'll go into the cause. We can divide these causes into four types. One is transient. Second, chronic. Third, antibody mediated neutropenia. Fourth is idiopathic. Okay. This transient neutropenia is when you collect the blood from the patient and store it for the long time. Before you process it, you can have a neutropenia in that patient. You can find some neutropenic defect in that patient. So that way you can call it as neutropenia. Or when the child is having a severe sepsis, that time also you can find a neutropenia in that patient. Okay. Next is chronic. In chronic we have types. So this is number 2. Chronic causes of neutropenia. So you can divide again this into congenital neutropenia and neutropenia that are associated with symptoms. So in congenital neutropenia we have, first one is failure of production, that is bone marrow defect. So failure of production from the bone marrow. For example, in aplastic anemia, you can have this neutropenia. Next is severe chronic neutropenia. Third, it can be a cyclic neutropenia. So these are the types in the congenital neutropenia. Next, we'll see the neutropenic associated symptoms. First can be primary immunodeficiencies. In primary immunodeficiencies, syndromes that are associated with the neutropenia are X-linked agammaglobulinemia and hyper IgM syndrome. They can present with neutropenia. Second, in glycogen storage disorder type 1b. Okay. Third, in Schwann-Diamond syndrome, the child will present with neutropenia. Fourth, in cardioskeletal myopathy. So these are the syndromes associated with neutropenia. These are the chronic causes of neutropenia. Third is antibody mediated neutropenia. So in antibody mediated neutropenia, first one is autoimmune neutropenia of infancy. Second, it is alloimmune neutropenia. So it is alloimmune neonatal neutropenia. Third is autoimmune neutropenia associated with primary specific immunodeficiencies. So autoimmune neutropenia is when it is associated with primary specific immunodeficiencies. So these are the antibody mediated neutropenic type. Okay, next is fourth one is idiopathic. In idiopathic, it is mainly chronic benign neutropenia. So among idiopathic, you will be having this chronic benign neutropenia. Fine. Next we will go into the treatment and how we are going to diagnose. This one diagnosis is you have to take a complete blood count, not just total WBC or not just hemoglobin count. You have to take a total WBC count you have to take first. In the total WBC count, next you will be doing your peripheral smear. In peripheral smear, you can find any defect, whether there is a multilobulated, the polymorphonuclear thing is affected or not, or the granulation defect is there or not, or there is an absolute reduction in neutrophils or not. So by using peripheral smear, so you will be taking in lab investigations. First you will do complete blood count. Next is peripheral smear. So in congenital neutropenia, you have a failure of production. So in failure of production, you have to find whether there is a reduction in other cell count also. So when there is a reduction in other cell count, next you will be doing their bone marrow aspiration study or bone marrow biopsy study you can do to rule out aplastic anemia, leukemia and other malignancies. Next, in fourth, in antibody mediated neutropenia, you have to do neutrophil antibody assays. So this in antibody mediated neutropenia, this will be positive. So you have to do neutrophil antibody assays. Next, when you suspect immunodeficiencies, primary immunodeficiency, then you will be doing serum immunoglobulin level. Okay. So these are some of the lab investigations in a child when the child have a neutropenia. Next is the treatment. So treatment depends on the cause. So this treatment depends on the cause, severity and clinical course. So the treatment depends on this cause, severity and clinical course of neutropenia. So when the child has a neutropenia, the child will have some serious infection. So you have to recognize the serious infection and there should be an early administration of parenteral broad spectrum antibiotic. So there should be an early administration of parenteral broad spectrum antibiotics. Second, you can also give the child when the child have a chronic neutropenia, prophylactic cotrimoxazole for chronic neutropenia. Third, we'll use GCSF, that is granulocyte colony stimulating factor can be used. What are the benefits of using this granulocyte colony stimulating factors? This can be where the child can experience a reduced number of infection. So the child can have reduced number of infections. Second, there can be a significant improvement in the quality of life and survival of the patient. There can be significant improvement in the survival and quality of the life of the patient. Okay. Suppose the patient is not responding to this. When the patient is not responding to this GCSF, that is granulocyte colony stimulating factor, then you have to go for bone marrow transplantation. Okay. These are the lab investigation and treatment of a patient with the neutropenia. Next we will go into the disorders of neutrophilic functions. Next will be disorders of neutrophilic function. First one is chronic granulomatous disease. So this is a congenital defect. So chronic granulomatous disease is a congenital defect in the enzyme NADPH oxidase. So it is a congenital defect in NADPH oxidase. Okay. When there is a defect in NADPH oxidase, there will be a reduction or reduced function of respiratory burst. What is this respiratory burst? I will tell you it in detail. Okay, one second. So we'll take a new page. So when a child is being infected with some pathogen, the initial response will be this neutrophil or this phagocyte or macrophage will come into play. When this neutrophil or a macrophage or a phagocyte, when it comes into play, it will engulf this. So it will engulf this bacteria. So when it engulfs this bacteria, it will form its vesicle. It will form a vesicle. This is a bacteria. Okay, this is a bacteria. So this will form a vesicle. This vesicle is called as phagosome. Okay. Inside this lymphocyte, that is a phagocyte, it will have a vesicle called as lysosome. So inside this phagosome with this bacteria and this lysosome will fuse together. So these both will fuse together. In the borderline, in the border of this phagosome, we'll have an enzyme called as NADPH oxidase. This NADPH oxidase will be present. This lysosome will stimulate the NADPH oxidase. This lysosome will stimulate this NADPH oxidase. So when this NADPH oxidase is being stimulated, it will undergo this oxidation reduction reaction. So this will undergo an oxidation reduction reaction to form NADPH2 NADP plus, and it will release a oxygen, which is again undergoing a reduction reaction. It will form a superoxide. This is a superoxide ion. This superoxide ion will then, this superoxide ion will then combine with a H plus to form H2O2 with the help of superoxide dismutase. This H2O2 and this superoxide ion, this both will help in killing this bacteria. So will help in killing the bacteria. So this reaction is called as respiratory burst. So this reaction is called as respiratory burst. In patients with this chronic granulomatous disease, this NADPH oxidase function is low because of a defect, congenital defect in the components of NADPH oxidase. So this will be low. So when this NADPH oxidase is low in this patient, so when a NADPH oxidase is low in this patient, consequently this superoxide ion, that is this O2 minus, will also be low, and there will be low H2O2 formation also will be low. Certain bacteria which is having this catalase positive, so that is called as catalase positive bacteria, will eventually react with this H2O2 and it will cleave this into water with oxygen. Okay, so when the catalase positive bacteria cleaves this into water and this oxygen, there won't be any reaction of this H2O2. Further, there will be a reduction in this H2O2 and there won't be any killing. So there cannot be any killing of the pathogen. So the child will experience, the child with chronic granulomatous disease will experience recurrent infections with mainly catalase positive organism. Understood? So what are these catalase positive organism? I'll write a few organism, okay? So examples of these catalase positive organisms are Staphylococcus aureus, Aspergillus, entry gram negative bacteria. Next can be Burkholderia. So these are the examples of catalase positive organism. So what can be the lab investigation for this? So lab investigation, that initial screening test can be nitro-blue tetrazolium test, that is NBT, nitro-blue tetrazolium test. In a slide, when you have this blood of this patient and you add this nitro-blue tetrazolium, when the child has a normal respiratory burst, it will turn into blue color. So this is called positive. Okay. Or when the child does not have this respiratory burst, or when there is a reduction in this respiratory burst, there won't be no change in the reaction or no change in the blood sample. This is the initial screening test. Second test, the confirmatory test can be, that is DHR, nothing but dihydrorhodonium test. It is dihydrorhodamine test. It is a quantitative test by using flow cytometry. So these are the lab investigations. Next, treatment. First you have to control the infections. So you have to reduce the frequency of the infections. Second, live bacterial vaccines such as BCG, these are being contraindicated. OPV, these are contraindicated. Final and most effective treatment is bone marrow transplantation by using a matched siblings sample that will be successful in these patients with chronic granulomatous disease. Okay, this is the first type of the disorders in neutrophilic function. Second is leukocyte adduction deficiency, not adduction, it is adduction. It is leukocyte addition deficiency. Here we will have three types: type 1, type 2, LAD, type 1, type 2 and type 3. Here mainly we will discuss type 1 and type 2. So normally when there is an infection, when a bacteria enters in your body, what will it respond? How it will respond? This neutrophil will respond, which is circulating in this blood vessel. So which is circulating in the blood vessel will come to the site where these bacteria are being present. So these neutrophils will come through the blood vessels where this bacteria has been present. So while coming, it needs a process, this process of transportation. So first there should be attachment of these neutrophils to the endothelium. For this attachment, we have this sialyl-Lewis carbohydrates that is present in the neutrophil. The sialyl-Lewis carbohydrate, this one, it is present in the neutrophil. It gets attached to this endothelium, that is selectins that are present in the endothelium. So when there is a defect in the sialyl-Lewis carbohydrates, we have this defect called LAD2. Then what is LAD1? when in LAD1, I'll write it here. In LAD1, there will be a mutation in CD18. So when there is a mutation in CD18, it will lead to defective beta-2 integrin. So when there is a defective beta-2 integrin, so it will, the chemotaxis, that is this percolation of this neutrophil into this, through the endothelium will not happen. This chemotaxis will not happen. That is chemotactic defect. So when the chemotactic defect is there, the neutrophil can't come to the site where there has been bacteria has been present. So this is the defect in LAD1. So there is an impaired integrin adhesion and this chemotactic defect. So this is about the leukocyte adhesion defect. So what are the symptoms the child can present with, or the clues how we are going to identify? 1. During at the time of the birth and during that infancy period, there will be a delayed separation of umbilical cord. This is in type 1. Type 2, there will be, in second, the child can have recurrent pyogenic infection. Third, there will be an absent pus formation. Only when this neutrophil come to the site where this bacteria has been present, the pus can be formed. Here the child will not have any pus formation, but the child will have recurrent infections. Main organism the child will have are Staph aureus and Pseudomonas in this. So normally when the child is born, we'll cut this umbilical cord. We'll cut this umbilical cord. So there should be falling of this umbilical cord by day 7. So how is this umbilical cord getting fallen? Is because of this neutrophil. So this neutrophil will come to in action to take places, and this neutrophil will it will engulf all this blood vessels and all this water and jelly here, and they will be dried. Then it will get fallen off. This will be the normal reaction. For this reaction to take place, there will be day 7. 7 days it will take place nearly. So when this is not taking place, it will lead to delayed falling of this umbilical cord. And the child will have a chronic bacterial and fungal infection. Fungal infection. And the wound will slow to heal. The healing will be slow. So these are the symptomatic clue. You can find the child is having a LAD defect, that is leukocyte adhesion deficiency. So diagnosis is based. The neutrophil will be present only in the blood vessels. So the neutrophils will get increased in number for the reaction of this bacteria that is being present in the body, but it cannot go into the site where the bacteria is present. So in lab investigation, when you take a total blood count, there will be an increase in the neutrophilic count. Then you can use this flow cytometry analysis to confirm your diagnosis. Treatment is hematopoietic stem cell transplantation is the treatment options for this. Plus you have to give this prophylactic antibiotic to this patient. Antibiotics and prophylactic antifungal like itraconazole can be used in this patient. So this is about the disorders of neutrophilic function, that is chronic granulomatous disease, and second is leukocyte adhesion deficiency. I have told only a gist of this. So if you need a detailed elaboration of these two diseases, I will take it in a next video. Okay. Next, disorders of degranulation. I'll cover this disorders of degranulation. So in just I'll tell what are the diseases. So disorders of degranulation is mainly Chidiac-Higashi syndrome. So this is it's an autosomal recessive disease. So the gene responsible for this is LIST gene. This is thought to regulate the vesicle transport. Okay, this is so when there is a defect in this LIST gene, it leads to decrease in phagocytic function. Therefore, the child can present with partial albinism. So for example, the child will present with partial albinism, that is hyperpigmentation of hair and the eyes, will be present in this child. The child can also have a recurrent infections of the skin, mouth and the respiratory tract. In a most serious cases, the child will go for HLH, that is hemophagocytic lymphohistiocytosis. Okay, so I will cover this Chidia-Kagashi syndrome as a separate topic. It's a vast topic, so I'll cover it separately. It's a separate 5-mark question for you, so I'll cover separately. So thank you. Please like, share and subscribe our YouTube channel. Let's all learn pediatric together. Thank you.